this one doc, what he would do is he'd come in every day. He would ignore the residents. He really didn't have much to do with them, at least not in front of the medical students.
Yeah.
Right? So we would, as medical students at that time, we were supposed to be on call every fourth night.
Okay.
On call means you're up all night going around with your resident to see patients.
Okay, you are in the hospital.
You're in the hospital,
Okay.
you're running around doing this. So this is every fourth night, right? Which means, you know, you over the course of a month, or you have about a week where you don't sleep at all. Right. You go the whole night without sleeping, right? So 1 week out of 4, in fact, I mean, just imagine trying to do that every month, right? 1 week out of 4 you're not sleeping. This is pretty common in the medical profession.
Because you would have stuff you need to be doing during the day too, you're saying?
Exactly, yeah. You'd come in, you'd work all day.
Yeah.
You would then work all night.
Yeah.
And then you work the next day until about noon.
Yeah.
This is how it was done at that time,
Yeah.
right? But here's the thing. So the normal policy in that institution was you come in, you write you work all day, you go all night. And then you were supposed to submit something called a history and physical document. What you were supposed to do was take one of the new admissions that came in from that evening, right? And then 4 days later, on your next on-call cycle, you were supposed to submit a written document that said, here's all the information I gleaned.
Oh, okay.
Here's my thoughts about possible diagnoses and which one I think is the most likely and what treatment we should do, right?
Okay.
So
Yeah.
everywhere else, all the other students, for the most part, they had 4 days to churn out this written report.
Yeah.
We had to present it by 8 a.m. that morning after we'd been on call all night, right?
And when did the night shift start?
I think it's about 7 o'clock at
Okay,
night. So you had from 7 a.m. to, and I'm sorry, maybe it was 8, whatever. It was about 12 hours approximately at night, right? And then you had to have this thing handed in by the time he showed up in the morning. So you had to write it overnight, right?
While you were supposed to be doing
While
these
you're supposed to be
rounds.
following your resident around and seeing patients, right?
Yeah.
So 2 things happen. The first thing is that we start, because he's required us to turn in this paper, right?
Yeah.
So we start saying, okay, residents, well, we need some time to write this.
Yeah.
We cannot follow you around all night. The residents get super angry with us for not following them around. So we meet with them and say, we can't, it was myself and another medical student, we say, look, we can't go with you. We have to write these papers. We're being required by our attending physician to write these papers, and we have to turn them in at 8 a.m. And you know this.
Right.
And their response was, well, that's not our problem. That's your problem. You need to talk to them. But if you continue to do this, like, we're going to have to write you down on your evaluation, right?
So, and would this attending physician be over these residents as well?
Yeah.
So they like that's their direct boss, and they just still would just be like, whatever.
This is the response.
I'm your boss.
This is the response
like,
we receive. Yeah.
Wow.
That's it. I'm your boss, and I want you to follow me around. And even though, so you see what I'm saying?
But there was no backup from this attending physician to be like, no, guys, I actually need them to have this paper in at 8.
We're
like,
at the bottom of the hierarchy.
Again, no communication across, and then you guys are screwed.
Right.
I mean,
yeah. So we're making our residents mad by not following. The culture at that place was you follow them around until they dismiss you. You can't go anywhere, right? And if you do, your name is mud, right? If you do that. So we're in a position of, well, but if we do that, then we can't finish our paper. And if we can't do that, then our attending will be mad, right? So what do? We just got stuck in this purgatory between these 2 things. So then what would happen is then you'd hand in your document. He didn't want you to just hand it in. He wanted you to give it an oral presentation. But before he would do the oral presentation, he would take you on about 2.5-hour walk arounds. So you'd walk around to see all these patients. And during that process, he would do a process that in medical parlance is called pimping, which basically means keep asking you questions. So I'm asking you questions about all kinds of different aspects of the patient and their care and diagnoses and what's the differential diagnosis.
While in the room with them or both, after?
Both while in the room, while walking around, whatever else, right? So
like quizzing you?
Yeah, but it's constant quizzing. So imagine you've been up since 7 a.m. the previous day, even earlier than that, right? You're showing up at 5 a.m., right, to go in. So you've been up since 5 a.m. the previous day. It's now 10 a.m. the next day, right? Okay? And you have somebody like just blasting questions at you the whole time, right? And then at the end of that, when you go through that whole process of walking around, now he wants you to give an oral presentation of this multi-page paper that you just had to write, right?
A few hours before, though, so it's not very recently in your brain that's fried at this point.
Yeah,
like,
this is the issue.
Is there any break in this night?
No,
not at all.
You just roll all the way through,
don't.
right?
Wow.
And then the thing was that there are different styles of this, right? So some doctors, when they do this, their goal is to teach you.
Right.
Meaning they're asking you questions. The point is not necessarily whether you get it right, whether you get it wrong.
Right. It's to be constantly seeing what you know, give more.
And to some degree, to help you learn a thought process, right? Okay, you don't know the answer to this. Why don't you know the answer to this? Well, let's explain what thought process would get you to the right answer.
Like partly like helping instill that flow chart within you. Like
that's precisely
for that. Okay.
That's precisely, and that's, if you're going to use that technique, not everybody does,
right.
But if you're going to use that technique, that is how it should be used.
That should be the goal. Like
for this doc, the purpose was humiliation. The point was to rub your nose in what you didn't know and how much more he knew than you did.
Really?
Oh, 100%. Yeah, 100%. That was the goal of the question asking process, right? So it would be, I'm going to ask you questions, right? If you don't know it, I'm going to just humiliate you for not knowing the answer to whatever the question is, right? In front of the whole team and everybody else, right? I'm just gonna tear you down for not knowing.
So this is happening in front of other people as well, yeah.
100%, yeah.
Just,
it's the whole team, the residents, everybody else that's there, right? So you're just getting dressed down for what you appear not to know. And so, there was one, there was one experience I remember having. The case was a guy that had come in with abdominal pain, right? And he had liver metastases or something like that. So, I wrote up my paper on potential causes of liver metastases in this case, right? The thing about this particular doc was that he really enjoyed cardiology. That was his thing. He knew way more about cardiology than any of us did at that point in time, right? So, and most of the cases we had coming in, a lot of them were heart cases. So we learned very quickly, if you do a heart case, he's going to just tear you to shreds because he knows so much more than you do about this. So we learned, the two of us learned, we probably shouldn't do heart cases because, if you don't want to just get blasted, you got to do something that's a little bit out of his area of intense expertise. So we would do this, right? So we'd pick side topics, right?
Yeah.
And so, I picked one that was abdominal pain. And I finished up my presentation. He's clearly very frustrated because there's really nothing that he can go to town on, right?
Yeah.
It's a more limited topic, which was intentional on my part, right?
You're being smart in how you try to dance around the
we're
abuse.
trying, right? So he says, well, tell me the differential diagnosis. Differential diagnosis means give me a list of possible diagnoses that could cause this symptom. Okay. So he says, give me the differential diagnosis for abdominal pain, right? So I'm like, okay. So I start naming diagnoses, right? Yeah. So I go on for about 2 minutes or so, naming everything I can think of that could cause abdominal pain. I finish up and he's like, ridiculous. You forgot hereditary spherocytosis.
Oh my gosh. Ridiculous.
Right.
Oh my gosh. How could you forget?
Right. And I'm like, you know what I mean? And I'm like,
right. I mean, when you type in Google, we now know that there are so many things that can.
I've never forgotten that though. To his credit, I've never forgotten hereditary spherocytosis.
Right.
Okay.
How often does it come up in your diagnosis for real though?
But it was virtually never. But it was, this was the goal, right? And so there were lots of insults. There was lots of tearing down, on a very personal, level, insulting your intelligence, insulting you as a person, not just you need to know more, right?
It was an attack.
You're an idiot, right? It's like this kind of thing. This is the dynamic. So, my co-medical student, right, started taking those papers, right? Yeah. I would try to write what my co-medical student started doing was cutting and pasting out of pre-written medical journals. So look up a topic, cut and paste, and slap it into the paper, and then read that, right? As the thing, that's right? Funny. He didn't know that this was going on, right? So he'd be like, "Oh, that's wonderful. What a wonderful." I'm right.
Oh my God.
Yeah, I'm like, well, that was written by a medical professional, right? That wasn't written by a medical student.
A med student.
You don't know this, right?
Right.
Okay. So I'm trying to do it allegedly the right way. I'm trying to write it myself, right? And you are just ripping me to shreds, right? Well, this is going. So this is the dynamic, right?
Yeah.
So I take that.
Which kind of goes to what we've talked about before of the type of person that ends up in medicine.
Yes.
Where it's needing to just check the box, not just check the boxes, but it's an achievement thing. He's accolading this person who's got all the right information, whether they've learned it or not.
Correct, right. Yeah. They have learned a way around, they've learned to achieve an outcome, right?
They've learned a way around.
Whether they learned that information or not is irrelevant, right? They learned how to present the appearance of knowledge.
Right.
Right. And I don't fault them for that. It was an extremely high stress, awful situation, right? But
points out a flaw.
That's what was going on, right? You're teaching them to find a way to give you the outcome you say you want, whether or not it has any actual effect on how good of a doctor they are or how knowledgeable they really are, right?
Yeah.
And you're making no allowance for the fact that this person, by definition, has less knowledge and expertise than you do.
Yeah.
You are a better doctor than them. That's why you're teaching them, right?
Right.
The point is it's not a battle of equals, right? This is a battle with a clear power differential.
Mentorship, for lack of,
except it's not, right? It's like a reverse mentorship.
Right.
So this was the dynamic, and this was the problem. So you learn to produce the desired outcome rather than go through the process that might actually make you better at the job in the long run.
Right.
So I take that dynamic and I went to the clerkship director at that time and said, "Hey, this is the experience we're having.
Yeah.
We're getting just torn to pieces.
Yeah.
What we're being asked to do is not comparable to what our colleagues, our other medical students are being asked to do by their attendings. We are being held to a different standard.
It was like you talked with your
Oh yeah,
class
100%.
and everything.
Yeah,
It was
we
like,
knew. We knew what was going on. Yeah. So I go present this, and he says, "Yeah, that's true. Yeah, we hear about this guy every year. Every year we hear about him. Yeah, he's like that." I'm like, okay, and so what's the plan? Nothing. The plan was nothing. The plan was, just suck it up. Like that's, we know he's like this. He treats everybody like this, and just deal with it. Like that's the answer.
You got the short straw. Like,
that's exactly what it was. Yeah. So and then in that same dynamic, so I had actually about that particular rotation, I'd written up like a letter outlining my stuff, and I sent him a letter. Yeah. And his response was, "I didn't read your letter. It's too long."
You sent it to your attending physician?
No, I sent it to the clerkship director.
Yeah.
So I documented the things and I sent him a letter. And his response was, "It was too long. I didn't read it. Just don't care." Right. So you just deal with it. Right.
Wow.
So again, this was right.
Yeah.
The vibe here is
put up with it.
You'll
be gone soon.
We have an institution. Right. We're going to do what we're going to do. If it's abusive, it's abusive. You should just live with that. Right.